I'm Diane Relbourne from the London School of Hygiene and Tropical Medicine in London, England. I have 3 questions, but I know that I got other opportunities to ask them, so I try not to be too greedy. Alan, when you talked about the consort statement right at the end, this is a point of information really, just to say that it's being updated actually as we speak. It's about to be submitted for publication, and thanks to Jeremy and Monica, we are actually bringing in something about ethics which isn't currently there in the previous drafts, and that's because all the consort statements work on the principle that ethics is a given, that informed consent is a given, and we don't specifically ask for that information to be reported. And that might be reflected in the empirical work that you've been doing, Monica, that doesn't show that. So based on your pressure and pleading, we're going to add this in the next draft. The second thing is just a point that always irritates me, which is that you're always talking about research subjects. And the way we all try and work is to consider the people that are taking part in our trials not to be subjects, but to be participants in the research endeavour. And so I know you've got lots of publications out that already have that in the title, but perhaps not to do that in the future. And then the last thing is really a question. Those were all points. Very often you talk about things that you're trying to contrast cluster trials with individually randomized trials, and all of you have been doing that. But a lot of the points that you make chime with me, who does a lot of work in emergency trials, as being not that different, where it's actually quite difficult to get consent in a practical sense. It may not be ethical to be trying to ask those questions. And so you often have proxies instead of gatekeepers. And so lots of the issues may be rather similar and not as distinct as perhaps we're trying to make here. So that's a rather controversial point to bring in, question to ask.
I think Diana's right in terms of there are some similarities with particularly sort of trials in emergency settings. I guess the issue is the cluster randomized controlled trials are a particular sort of family of trials where these things are always problematic, and there are an increasing number of cluster randomized controlled trials. And so the feeling was, by starting to try and understand what the ethical issues in cluster randomized trials are, that could help the discourse between trialists and the research ethic boards that might be useful. But certainly we're likely to be able to learn things, and also our findings may be relevant to people planning other types of studies. So I think it's a good point.
I'm Kathy Lohr from RTI International in North Carolina, USA. This is a question probably for Jeremy, but perhaps all 3 of you might care to respond. I haven't heard yet anything about the complications that might arise if, in fact, you were to pay any kind of incentives or honoraria or whatever you might want to call it to either the people who are in the clusters, let's say the GPs or whatever, or possibly to the people from whom you may care to collect data, which would be our research participants, our patients, or whatever. And I'm wondering if you've considered that as a peculiar aspect that complicates even more the design or what might happen with respect to the ethics issues when you're paying some people something and perhaps not paying others that you might should have.
When we did our initial scan, it wasn't an issue that we identified as being particularly pointed for cluster randomized trials. And as you were talking, Kathy, until your last sentence, I was thinking, well, this isn't particular to cluster randomized controlled trials. Your last sentence, which actually pointed out that you may end up if, or there may be, if you like, an inequitable distribution of incentives because of the structure of a cluster randomized trial, made me think we need to think about it. I think what will happen is we may have some discussion today and over the next few days, but we're going to, at some point in time, if we identify new ideas that require some thought, think about them. Because when you look at the 6 questions, they've been subject to basically 3 years of fairly intensive thought, and I don't think any of us would want to give an immediate response, but I think we will take that away and think about it.
So the first question from the webcast comes from Emma Veach, and the question is along the lines of, the presentations outline some major hurdles to overcome in identifying ethical issues in cluster randomized trials, and the question sort of relates to the point raised by the first live question here in Ottawa, is irrespective of generating guidelines for ethics committees on how to address these issues, do you think there's a need to further encourage trialists to report in greater detail how ethical issues were considered in the conduct of their trials?
Could you just repeat the last bit of the question,
Sure.
Andrew?
Sorry. So, irrespective of generating normative guidelines for ethics boards and ethics committees, do you think there's a need to further encourage trialists to report in greater detail how they considered and dealt with ethical issues in the conduct of their study?
With the next iteration of the consort extension for cluster randomized trials, we will actually be adding some recommendations regarding ethics reporting.
Question from Michael Vensing in the Netherlands. Triggered by some major recent scandals in science in my country where researchers had completely fake data, I wondered whether there's anything specific to cluster randomized trials along the lines of addressing scientific integrity issues that need to be addressed. And so whether there's something specific to cluster randomized trials or not that we need to consider.
Hi, Michelle. Thank you for the question, as Martin said. My immediate response is I'm again trying to think about what is peculiar to cluster randomized controlled trials. So the whole issue of research integrity is clearly a major issue across all of science. And we have lots of examples where current mechanisms have failed to, I think, sort of ensure integrity. But my immediate view is I can't think of any obvious things in cluster trials that are different from patient trials or other ideas. If either you have and you want to come back, that would be great, or if other people in the room have, that would be really good. But I can't think of anything that would sort of immediately say, this is unique to cluster trials, as opposed to this is something that's problematic across all of the science that we do.
No, I was just saying maybe issues related to the appropriateness of a particular gatekeeper in a cluster trial. Is it appropriate for a mayor of a city to randomize their residents? Did they elect their mayor to do that? I'm not sure. I mean, my mayor tried to widen my street by 8 feet the other year without asking my consent, but that might be a related issue.
Hi, I'm Sarah Edwards from London, UK. I thoroughly enjoyed all your presentations, and I've got umpteen things going around in my head, but for the sake of everybody's patience, I'll limit myself to one question and one brief comment, if I may. The question is for Monica. Did you attempt to do any analysis of interactions between the responses? So, for example, I was thinking in particular the extent to which there might have been an association between people identifying research subjects and their opinions on the need for consent, whether they sort of went hand in hand.
I expect that that is likely the direction that we will go, because as you will see later this afternoon, a little bit later, we do actually find an interaction between who we would consider to be research subjects and the need for informed consent. I won't give that away. But we're at the very beginning stages of analysing that data, and so that will be something interesting to look at. Thanks, Sarah.
Thank you. And my brief comment is for Diane, just on the whole business of the words we use to describe people in research, research subjects or research participants. I wonder to what extent we should be looking at how involved individuals are before labelling them participants. I mean, there will be some cases in cluster designs where the individuals aren't obviously doing anything. They may not even know that they're part of a study. So to call them participants might be a bit misleading.
Thank you. Roger Saul from the University of Vermont. I assume that all cluster trials that are being conducted today are registered. And I don't know what information is available in terms of registration websites And I guess my question is twofold. One, have you looked at registration websites to see if people are describing more of these important features currently, or even if this type of information is asked for by their websites, so that if not, as part of your consort statement, since these things have to be planned prospectively, that really should be wrapped into, I don't mean to make more work for your group, but it should be wrapped into that. And perhaps since journals are always loath to publish some of the methodology, that's the place where a lot of this very rich and important information could be shelved. So what do we know about registration sites?
So I've registered trials, cluster trials on registration sites. I've not looked at the fields and the extent to which they represent sort of unique challenges in cluster trials. It would be worthwhile following up with that. I suspect cluster trialists will register their trials for exactly the same reason that individual patient trials will, because of the ICMJE and other requirements from funders or regulators to do that. So I don't think there's a particular problem with registration. Whether it is fully informative for cluster trials is less clear. And I do know that studies that have tried to look at the quality of data in trial registries have found that they're pretty poor, that you have missing data or fields are inadequately completed. So there may be an issue about kind of either guidance or more structured reporting within trials registers per se. The final thing also is I think what we probably need to do is try and move for making trial protocols more readily available. And they may be something that can be posted as part of a trial registration process, or to put a plug in Trials, which is a Biomed Central open access journal, which I'm an editor-in-chief on, and journals like Implementation Science that Martin is the editor-in-chief on, routinely publishes study protocols to allow the trialists to have the length to actually describe what they've done.
Great, thank you.
Yeah, I don't think there's been much guidance on what elements of a cluster trial to put in a registry. So your point is very well taken. For example, just with respect to sample size, you could specify the number of clusters, or you could specify the number of individuals per cluster, or both. So I think that's a very good point.
Yeah, my guess is that it's a square peg and round hole thing. It may actually be steering investigators in the wrong direction as they think about all of the sample size issues and who's being randomized and the ethical issues. And so I think that changing people's thoughts around registration might be very productive. But actually I take Jeremy's point that getting the whole protocol out there is probably where it's going to be.
Hi, good morning. I'm Dr. Abha Saxena. I'm from WHO in Geneva. I have a couple of comments and perhaps one question. First comment was I agree with the first speaker on some of these guidelines that you're developing are not necessarily only for cluster randomized trials. They apply very much to other types of research studies. For example, we've been doing work on patient safety research, but also health systems research more broadly rather than just the cluster randomized part of the health systems research. So at some point in time, I think we'll have to sort of say, okay, let's get all this under one umbrella, but perhaps not the time. The second comment I have before I come to my question is related to the point about how many articles reported, whether they were reviewed by ethics committees or informed consent was taken, etc. And at one level, I think that a lot of the people who are doing these type of studies, I think there's a disconnect in their mind for, at least for some of these studies, the disconnect being that this is not really research. We're just trying to see how practice, we're trying to tinker with practice. And so it's not really research. So perhaps all these things don't work for us. We don't need to do all this. But then because we're using research methods and we want to publish, so there is that disconnect. And I think somewhere along, if we can have a better clarification for researchers and for others to say what is research, what is not, that might be useful. Doesn't mean that if it's not research, it doesn't have ethical implications, but that the other things that kick in if it's research. And third, my question was, you said who should be considered a research subject? And I was just wondering, when you talk about who should be a research subject or participant, when you say who should be considered a research participant, are you thinking in terms of so that informed consent should be taken? So is that a research participant equals consent? Is that the issue? Or is it the issue that research participant means participation? So just a clarity on what is meant by this particular question would be useful.
For us, I believe the implications of a research subject was that it would be somebody who would need the protection of the ethics review committee, and not necessarily imply that we need to seek informed consent. There will actually be a detailed presentation about that just in the next session.
Hi, I was vaccinated last week, so I don't worry about closeness of microphone. My name is Carmela Krleža-Jerić, and I work at a CHR, which is Canadian federal government funding agency. It's nice to come after other people so you can comment on what they commented. As far as the registration goes, CHR is funding, what I now learn is cluster trials, because we are funding both randomized trials, which are clinical, and randomized trials of groups of people. According to regulators, I don't know of any regulator who is asking registration of those trials. Usually regulators are looking at new drug and the testing of the new drug. So seldom cluster trials will go there. So that's the tiny issue. Fortunately, journal editors are saying we won't publish unless. So that's the comment about the registration. And then my question actually was, I've been, before I came to Canada, involved in what we called interventions. We didn't even think it was research. I worked in public health, and we were doing smoking cessation or whatever, and followed up. And I think some of them even got published. That was the beginning of my career. But so my concern here is that we should probably look into different cluster trials according whether you test something new intervention or you are applying the known, like smoking cessation is not a new discovery. Sir Richard Dole did it before 50 years ago, almost. So in that case, or let's turn it around the table and say how dangerous is, potentially dangerous is intervention to lower participants, so to say, not a cluster. Let's say we talk to GPs and they do something different with their people, or we talk to. So I think we should distinguish those two types of cluster trials when we are talking about consent form or everything. And I'll give you an example of the study we did. We randomized two groups of hospitals, doctors, and in Yugoslavia in those days, everybody was covered by health insurance. So we were there was too much of antibiotics use, so we were educating some of them when to use antibiotics and how, and some of them didn't. And we compared their prescription habits. And they changed after education. So that was actually what you would call genomic cluster randomized trial. Probably we didn't call it that way. And we didn't look at it as the need to do any consent of people who were given prescriptions. Maybe we were wrong, but basically I think people were better off without too many antibiotics. But I mean, that was the implementation of the knowledge, because if we go too far, then whatever we educate people in medical school should go through consent form or graduate courses. Anyways, so that's my question. Thanks.
I think there's issues about, are you doing the study to generate new knowledge, or are you doing a program which is not about generating knowledge? So that's one distinction, that if you're just doing programs without wanting to generate new knowledge or only to monitor the program results, then really that takes you out of the research environment. But I think what you'll get later on in the morning is you'll also get a discussion about when things like waiver of consent might be appropriate, and they certainly take into account some issues around the likely risk that potential subjects may incur as part of that process. So I think it'll be interesting to reflect on the next presentation about whether that at least addresses in part your comment, Carmela.
It's always generating new knowledge. We know that nets help malaria, but we wanted to see what. Or we know smoking cessation, we know smoking is not good for your health. So it's always new knowledge, but it's not necessarily risky. So that's the second part, right?
But you're still doing research.
Yes.
And so the subjects who are in research are basically entitled to having ethical protections. And so as soon as you say you're generating knowledge, whether it is social science knowledge about how do we change behaviors, whether it's sort of practical implications about what happens if we change co-payments or whatever, if you're doing that for research purposes, put you into the research bucket, and then we need to sort of think that people are research subjects and then think about what are the appropriate protections. So I think once you make that distinction, if you're in the research bucket, we have to make a decision about then what are the benefits and harms and what are the appropriate consent or waiver of consent that's appropriate in that setting.
Peter Tugwell, here from Ottawa, but over the weekend actually I had a few manuscripts around the Zelen approach to allocation, and I noticed in the on the slides that most of them were the correct answer was to collect the information before the intervention started and before allocation. So I'd be interested in your views and whether you will be addressing it over this next few days in terms of whether the Zelen design is acceptable and what the ethical guidelines will be for that. There was a series of studies that came out of Holland that just were working on that and ran into some major ethical problems. Alan?
Well, it's very interesting that the Zelen design has proved very controversial from both a methodological and an ethical perspective in the context of individually randomized trials in cancer. But for years, the Zelen design has been implicitly used in cluster randomization trials without anybody objecting or perhaps even noticing. That is, people are randomized, say, to either an experimental group or a control group of family practices. The control practices may not even be aware they're in the study, and the experimental practice patients only are applied informed consent after they've been randomized. And that, of course, is the essence of the Zelen design, where informed consent is obtained not before but after randomization. So to me, it's just interesting that what has been very controversial in individually randomized trials vis-a-vis the Zelen design has been regarded as routine in cluster randomization trials.
Nick Burkett, I'm also at the University of Ottawa. I've been working way through a book by Margaret Somerville recently, which is talking about individualism and collectivism. And my question relates to that, but will those sort of issues come into play? It seems that ethics boards are very much focused on individual rights and individual decision-making, and to a large extent ignore the collective benefits and collective rights. I guess the question that really comes up, though, is in the cluster situation. What do you do if you get, because clusters are going to be heterogeneous, and as you move from smaller to larger clusters, you get more and more heterogeneity. Politically, we're never unanimous in anything, and there's many perfectly legitimate situations where, say, the fluoridation example that was given, some people may legitimately say, I don't want to consent to have fluoride in my water, and other people want it in their water. How do you combine those conflicting but perfectly legitimate perspectives into a consent process for a cluster trial? There may not be an answer to that, but I'm curious if that's the sort of thing you're thinking about.
Well, I think actually this will be addressed in some detail throughout the conference, but it's very true that you have interventions like water fluoridation, for example, where it's very difficult, maybe impossible, for someone to escape the intervention. So other speakers will talk about that in much more detail.
I mean, it's not on the precise comment you made, Nick, but the other area this will come into is the issue about clinical equipoise. That individual patient randomized trials, as often at the individual relationship between the clinician and the patient, whereas often in cluster trials you're trying to generate different types of knowledge that will have value to different people. And so I think one of the things we've been trying to think about is who can make those kind of, what are those the appropriate judgments where you may be looking at sort of basically the cost effectiveness of, say, a knowledge translation intervention that is really at the healthcare system level, the knowledge is going to have value, but not at the particularly individual level. And so I think that's also another area where this will come into.
So I don't want to squander this last question. It's a really basic question, which is how common is it in the practice of cluster random trials for there to be data safety monitoring committees?
I think that major cluster randomization trials now routinely form independent data monitoring and safety committees. I'm on several myself.
So just one, yeah. Okay.
Well, I was going to say, I think it depends on what the cluster trial is. So I never have had a data monitoring committee because I'm not sure. I mean, I think some of the issues are likely what the balance of the harms are, and also actually sort of detecting a proper benefit signal is a real issue in these. So I think there's a variability, and it may be particularly kind of what the perceived benefits and risks of the kind of choice or changes that you expect as part of this. So when I'm randomizing hospitals getting different quality improvement interventions, the likelihood of harm is very, very small. We have no idea what the likelihood of benefit is, but yeah, we haven't.
But the data quality and the cluster accrual, for example, could raise concerns about whether you're going to reach adequate power. And so there's sort of parallel issues even if there aren't safety issues, correct?
Well, but often in cluster trials, or the ones I do, you know what the cluster accrual is at day one. Yeah, it's not sequential. So you may have issues around identifying patients within clusters, but normally for the number of clusters, you actually know that we have 90 family practices that we're going to recruit. It's not like a patient trial.
Got it. Okay.
I think it also depends upon the nature of the intervention and the nature of the outcome. I'm on a data monitoring committee now involved in administering vitamin A to neonates and looking at 6-month infant mortality. Well, there I think it would be almost irresponsible not to set up a data monitoring and safety committee. One issue that arises, though, is that stopping rules for individually randomized trials are well established in the literature, but not so well established for cluster trials. But from an ethical point of view, I think there's no reason to avoid data monitoring committees in cluster trials and in individually randomized trials.
Okay, thank you all very much for your questions. We're going to break for coffee. Could you please join me in thanking the speakers for the first session?